Okay, hello, my name is David Sweet. I'd like to start by thanking the organizing committee for allowing me to give a lecture at your Congress in Mexico 2024. I'll begin by showing my disclosures. I have received payments in the past for lectures from the following companies. What I want to do today is to discuss an approach to management for preterm babies at risk of RDS in the context of the most recent European RDS guideline, which was published in 2022. It's due to be updated, so hopefully I'll go through some of the areas where things are changing now, and we will discuss some of the current controversies. The European RDS guidelines group is made up of 14 neonatologists from different European countries. In the middle, you can see my mentor, Professor Henry Halliday, who sadly died about 18 months ago. So we have dedicated this version of the guidelines to his memory. And why do we need guidelines? Neonatologists all know what to do with babies with RDS. We know that they benefit from prenatal steroids. We know that they need support after birth with supplemental oxygen, non-invasive respiratory support, and occasionally mechanical ventilation, along with surfactant replacement therapy, as well as good general supportive care. Many of the interventions that we use are life-saving, but it is clear that some of the things that we do have also got the potential to cause harm. For example, too much oxygen can be toxic, or mechanical ventilation can injure the lungs. And thankfully, many of the things that we do have been subjected to randomized controlled trials. So it is important every few years to look at the evidence to try and make sensible recommendations for what we do. And this is what the RDS guidelines group does. It tries to review the literature, make recommendations, and then grade the strength of evidence supporting those recommendations, and also grading the strength of the recommendation, with a grade 1 being a strong recommendation that something should be done, grade 2 if there's maybe a little bit more uncertainty. The guidelines, of course, begin before birth. We should be working closely with obstetricians, trying to optimize outcomes. Mothers should receive prenatal steroids. We should be making sure babies have magnesium sulfate on board, and babies should be transported for delivery in large perinatal centers if they're very low birth weight. I'm not going to go into all the details about that now. I'm going to begin with how we should approach a baby at risk of RDS in the delivery room. The sort of things we have to think about are the timing of cord clamping. Should we do resuscitation with the cord intact? What about the role of cord milking? And we also review all of the evidence of devices that are used for monitoring and supporting babies in those first breaths in the delivery suite, such as the different CPAP systems and interfaces and devices for monitoring well-being. And we also have to think about how we can optimize temperature control in the delivery room. So to summarize the aims of what we want to do for supported transition, we want to aim, of course, to delay cord clamping because it saves lives. We want, if possible, to avoid routine intubation. We want to try and stabilize babies using CPAP if we can and avoid excess bag and mask ventilation. We also want to avoid too long having to hold a face mask on the baby. And at the same time as we're doing all these things, we want to try and avoid hypothermia. So imagine we're attending the preterm delivery of a baby at 27 weeks gestation. During the first minute when we're trying to do this delayed cord clamping, what should we plan to do with the baby? Well, there's been some studies to suggest that the very simple act of repeated tactile stimulation may be enough to stimulate babies to breathe a little bit more. This study from the Netherlands in 2018 was quite a small trial of just 23 and 21 babies in either arm, but it was designed to look at whether just stroking the baby's back on a regular basis would help them to breathe more. And you can see their FiO2 at the time of transfer to the neonatal unit was better in the babies who had repeated stimulation. So perhaps it's just enough to spend the first minute trying to stimulate the baby to try and get them to breathe by themselves. And then there's another school of thought which suggests that we should try and aim to do the baby's resuscitation with the cord intact. And there's various devices now which have come on the market which enable the baby to be kept warm while we can provide CPAP, intubation, surfactant, all without cutting the baby's cord to move them to the resuscitator. And the studies have shown that these techniques are feasible. It is possible to do full resuscitation with the cord intact. But the key question is, do babies really need this? Because the vast majority of babies, when they're born preterm, are not asphyxiated. And this observational study from Dublin has shown us that if you look at the videos of babies when they arrive at the resuscitator, most babies are actually already crying or breathing by the time you have them on the resuscitator. And this is a study looking at babies with early or delayed cord clamping. The ones with delayed cord clamping, more than 60 seconds, only 8% of babies were neither crying nor breathing. So there's only a very small proportion of babies for whom they might achieve benefit from having devices to allow physiological cord clamping. What about the act of placing a face mask on the baby to try and help stabilize them by giving CPAP right from birth? Well, it's also been shown that it has the potential to cause some problems because of this trigeminocardiac reflex, which can lead to apnea and bradycardia. This is another observational trial from the Netherlands, where they looked at videos of babies who were arriving on the resuscitator. More than 430 babies' videos were reviewed. Only 15% of babies were not breathing when they reached the resuscitator, and these babies obviously needed to have face mask applied to receive positive pressure ventilation. The vast majority of babies who were breathing when they reached the resuscitator, once they had the face mask applied, around half of them stopped breathing and they needed to go on to receive positive pressure breaths. So there's a question about whether we're doing good by quickly applying a face mask to a baby who's trying to breathe by themselves. And are there any alternative CPAP strategies that we can use if we don't think putting a face mask is a good idea? Well, yes, there are. In large parts of Northern Europe, they use a soft nasopharyngeal tube with a Benveniste valve to provide CPAP. And then in Scandinavia, they've developed this new nasal interface for resuscitation called RPAP. This is the system that we're using in Belfast. And if we like to practice evidence-based medicine, the RPAP system has actually been subjected to a clinical trial. 246 live-born infants who were randomized to getting RPAP or the old system of T-piece with face mask. The average gestation of the infants in the trial was 26 weeks. And the study was powered to look at the outcome of needing intubation or dying in the delivery room. The baby stabilized using RPAP had 33% need for intubation compared to 45% with the old system, which was a statistically significant result with no differences in secondary outcomes or safety variables. So having a careful think about how you provide this initiation of CPAP is also probably quite important. So to summarize the current recommendations for delivery room stabilization, we are, of course, saying that we should delay cord clamping for at least 60 seconds in preterm infants because it saves lives. If delayed cord clamping is not feasible, then it's reasonable to consider umbilical cord milking as an alternative, but only if the infant is more than 28 weeks gestation because of the risk of intraventricular hemorrhage in small infants. We should use a T-piece rather than a self-inflating bag and masks because the T-piece allows us to generate PEEP. If the baby is breathing spontaneously, then we should, where possible, stabilize using CPAP, and we should only give lung inflations if the baby's apneic, starting with pressures of about 20 to 25 centimeters of water over 6 centimeters of PEEP. We should control oxygen using a blender, starting in about 30% for babies less than 28 weeks, and for babies above 32 weeks starting in air, and we should make adjustments up or down guided by pulse oximetry at the baby's right wrist, and we should aim to achieve saturations of 80% or more within 5 minutes. And we should reserve intubation only for babies not responding to positive pressure by face mask or nasal prongs. And we should do all of the stabilization with the baby inside a plastic bag under a radiant warmer, and where possible using humidified gases in order to prevent the risk of hypothermia. Now you'll notice I haven't mentioned surfactant yet as part of our delivery room stabilization. So coming on to talking about surfactant, what are the considerations for surfactant therapy? Obviously, which surfactant should we use? When should we give it? Are there any infants for whom we should be giving surfactant prophylactically? How do we decide if surfactant is needed? What's the role of lung ultrasound? If we're going to give surfactant, how best to get it in? So traditionally, it's been given through an endotracheal tube, but then there's been studies looking at thin catheter surfactant. There's been even more recent studies looking at laryngeal mask surfactant. There's also been work on surfactant nebulization. So these are all the things the RDS guidelines group are tasked with considering whenever they're writing guidelines. So to begin with the issue of prophylaxis, the RDS guidelines group's recommendations have evolved over the years. In the first version of the guidelines, we recommended that all babies under 27 weeks should receive surfactant prophylaxis. The COIN trial was published in 2009, and after this, we dropped the gestation recommendation for prophylaxis to less than 26 weeks. And then a Cochrane review in 2012 was suggesting that routine intubation for prophylactic surfactant was potentially doing more harm than good. And since then, we have not been recommending surfactant prophylaxis. But this is one of those issues that may change in the next version of the guidelines. And you can see why we made these recommendations. The first recommendation in 2007 came from a Cochrane review in 2001, which was comparing prophylactic surfactant to babies left being managed on head box oxygen. And obviously they do better if they're given surfactant rather than head box oxygen. Further studies in between 2000 and 2010 randomized babies to prophylactic surfactant or initiation of CPAP and then rescue surfactant. And these studies were shown in a subsequent Cochrane review in 2012 to suggest that starting CPAP is better than routine intubation for prophylactic surfactant. And this is the Cochrane review that informed that decision. This was Rojas Ray's review from 2012. And you can see this is looking at the intervention on terms of the outcome of chronic lung disease or death. And you can see the forest plot lies to the right of the line of unitary favoring controls, which means that we thought that routine intubation for prophylactic surfactant was potentially causing more harm than good. But you've got to remember that these studies that were done between 2000 and 2010 weren't using thin catheter surfactant administration. Many centres in Northern Europe, when they started to develop thin catheter surfactant, developed policies for routine surfactant in the delivery room using the thin catheter, even in the absence of clinical trials to show that this was a beneficial thing to do. And they have become so convinced that this is the right thing to do that they will not change now. And you can see you could look at data from these centres, which has been published. This is the German Neonatal Network data published 2022, where they're able to compare the outcomes of infants who get their surfactant by thin catheter compared to those who get their surfactant through an endotracheal tube. Now, obviously, this isn't a randomized controlled trial, but the outcomes seem to be better in terms of reduction of death or BPD than the infants who receive thin catheter surfactant, which is normally given prophylactically, 37% BPD risk compared to 54% in those that get endotracheal tube surfactant. And it's only been very recently that we're starting to get evidence coming through from randomized controlled trials that this may in fact be the best approach. The study, the CALI trial, was published just last year in the New England Journal of Medicine Evidence. In this study, they randomized 180 babies, 24 to 29 plus 6 weeks, who were on CPAP. And they were randomized to being started on caffeine and giving a dose of thin catheter surfactant, then back on CPAP, or starting them on CPAP and giving them caffeine within the first 2 hours of life. And they had predefined criteria for intubation of pH less than 7.15 or apnea, etc. And the primary outcome of the study was the need for intubation and the need for the repeat surfactant and outcomes like BPD. And the study showed us that the thin catheter surfactant does in fact reduce the need for ventilation by half. And although the study wasn't powered to look at outcomes like BPD or oxygen dependency at 36 weeks, we can see there was a significant reduction in the incidence of BPD in the infants who received surfactant by thin catheter. So perhaps the 2025 RDS guideline will be moving back towards recommending prophylactic surfactant, but using a thin catheter technique in the delivery room where possible. So moving on then to, if we haven't given prophylactic surfactant, then when should we give surfactant? And the last version of the European guidelines suggested that we should give surfactant early in the course of the disease. And a suggested protocol would be to treat babies with worsening RDS when the FiO2 exceeded 0.3 on a CPAP pressure of at least 6 centimeters of water, or if lung ultrasound suggested surfactant need. This is quite controversial because where did this figure of 0.3 come from? Because other centres that have looked at the same evidence have come up with different answers. So this is the Canadian guidelines for surfactant replacement therapy, which was published in 2021. And it suggests that infants with RDS whose oxygen requirements exceed FiO2 of 0.5 should receive surfactant replacement therapy. So you can see, that this is a little bit of a conundrum. Recently, there's been a systematic review looking at all studies where different FiO2 thresholds have been used to try and determine if they could get an answer from this, a systematic review and network meta-analysis. And in this, they showed that the best ranked discriminator was an A over A PaO2 ratio of less than 0.36, which corresponded to an FiO2 of between 0.37 and 0.55. So they suggested that 0.4 was better than higher, and given that there was no evidence to compare 0.3 to 0.4, that we should potentially recommend 0.4. But there's a problem with these large network meta-analysis because they are taking data from studies which are spanning several decades, and respiratory care has obviously evolved in this time. Some of the trials were testing thresholds on babies who are already ventilated. Some were comparing Ensure with mechanical ventilation. Some were comparing thin catheter with Ensure. And nowadays we believe that it's best to use non-invasive ventilation with thin catheter surfactant. We don't have studies which compare varying thresholds of FiO2. So how do we justify suggesting an FiO2 of 0.3 as the cutoff for when we should treat with surfactant? And I'll try and explain that to you over the next couple of slides. We know from studies that were done early on that for babies already on mechanical ventilation, it's better to give surfactant early in the course of RDS compared to later in the course of RDS. This is a Cochrane review of babies who were already ventilated and then randomized to early versus later surfactant. And you can see the forest plot lies to the left of the line of unity, favoring early in terms of reducing the outcome of death or chronic lung disease. So we all believe that if you're going to need surfactant, then the earlier you give it, the better. But this creates a conundrum for babies on non-invasive respiratory support, because obviously we want to try and avoid annoying them by intubating them or doing laryngoscopy. And what evidence do we have of giving it earlier for babies who aren't on mechanical ventilation? Well, there is one trial from almost 25 years ago now from Henrik Werder, which he had babies on CPAP, and then he randomized them to getting Ensure earlier in the course of RDS compared to later in the course of RDS. And he was the person that was using the A over A PaO2 ratio. And he showed us that in the group that got their surfactant earlier, they had less mortality and they had less need for mechanical ventilation, which was statistically significant. But when the A over A PaO2 ratio involved doing blood gases, and it corresponded to sort of a range of FiO2s. And the early group, in fact, were getting their surfactant between 0.37 and 0.55, and the later group between 0.57 and 0.77. So how early is early enough is the key question, and this is what I'll try and explain next. So around 10 years ago, we have data from Peter Dargaville in his Australian unit, where he was preparing for the Optimus trial. And in his unit at the time, they were intubating babies for surfactant administration when their FiO2 exceeded 0.45. And he was able to show us that by observing these infants who subsequently ended up getting surfactant, that obviously their FiO2 will be gradually increasing as they make their way towards 0.45. And by using mathematical modeling and receiver operator characteristic curves such as these, and look at the sensitivity and specificity of various cutoff points, he was able to show us that you could predict which infants were going to fail CPAP and need surfactant at an earlier time point than waiting till they reached 0.45. And the best cutoff was around 30% for babies less than 28 weeks gestation, which happened at about 2 hours of age, and also at about 30% for more mature infants, but it happened later at about 6 hours of age. So he was suggesting that 0.3 might be a useful guide, but you can see the ROC curves, not in a good ROC curve would go right up like this, and this one is not a perfect system. So are there any better ways to determine when we should treat with surfactant? Well, we now know that we believe that thin catheter surfactant is best. So really we should focus in on the studies that are looking at LISA surfactant. And there are lots of studies now of thin catheter surfactant out there in the literature. I'm not going to go through all of them, but they can be broadly divided into two groups. We've got the studies where thin catheter is compared with just not doing anything and continuing CPAP. And then we've got other studies comparing thin catheter direct head-to-head with surfactant given via an endotracheal tube. Now, we're particularly interested in the good quality trials, and we're interested in the trials which are looking at the outcome of reducing BPD. And this allows us, by picking the better quality trials and the ones of babies less than 30 weeks gestation, we can actually pull out quite a lot of these smaller studies. And we're left with 3 sort of fairly good quality trials, 2 of which were comparing LISA comparing with nothing, and 1 of which was comparing LISA in a head-to-head trial with surfactant by endotracheal tube. And you can see all of these studies actually used the FiO2 entry threshold of 0.3. So we'll start with this last one, the NINSAP trial, which was published in 2015. So non-intubated surfactant application versus conventional therapy. Babies between 23 and 26 plus 6 weeks gestation who were on CPAP requiring more than 30% oxygen were randomized to thin catheter surfactant or intubation and ventilation with endotracheal tube surfactant. And for both groups, ventilation was mandated if the FiO2 exceeded 0.45 or the pH went less than 7.15. And the primary outcome of the study was the outcome of death and BPD at 36 weeks. But there was also pre-planned secondary outcomes, such as survival without significant complications like BPD, IVH, NEC, ROP, etc. And the results of the NINSAP trial, the primary outcome wasn't statistically significant. There was a trend to improved survival without BPD, which wasn't significant, but there was a significant reduction in the number or improvement in the survival without major complications. And also there was a lot more babies that didn't need any mechanical ventilation, even though these babies were very immature. And obviously, most of the 23 and 24 week gestation babies didn't need ventilation, but the ones at 25 and 26 weeks, some of them got away without it. And this may be why we get a reduction in these major complications. So we can say at an FiO2 threshold of 0.3, it's better to use thin catheter surfactant than intubating and ventilating and giving surfactant. And then if we look at the other large trial, the largest study of thin catheter surfactant is the Optimist trial. It was in babies 25 to 28 plus 6 weeks gestation. They were eligible if they were on CPAP between 5 and 8 centimeters of water and required more than 30% oxygen within the first 6 hours of life. And these babies were randomized to getting a dose of thin catheter surfactant or a sham procedure. So there was an attempt at blinding, and sham just meant the babies got nothing and they were just kept on CPAP. And both groups were intubated if the FiO2 exceeded 0.45. And again, the primary outcome was the composite outcome of death or BPD at 36 weeks gestation. And from Optimist, again, there was a trend, but not statistically significant, towards improved outcome for babies who got thin catheter surfactant. But there was a significant increase in the number of survivors without BPD if they had thin catheter surfactant. Again, there was a reduction in the risk of pneumothoraces and the need for intubation within 72 hours of birth if the infants had received a thin catheter surfactant. So from this, we can say that at FiO2 0.3, it's better to proceed with thin catheter surfactant than just leaving the babies alone to get worse when their FiO2 goes up to 0.45. So when you put those two studies together, it seems that we have the answer at the moment that 0.3 is a reasonable point at which to consider intervention with thin catheter surfactant. So if we aren't going to use the FiO2, which is a bit of a blunt tool, is there any other way that we can predict surfactant need? Well, you've already seen that you can use things like the A/A ratio, but it requires blood gases, and clinicians prefer not to do that if we can avoid it. There's also the respiratory index, which is a measure of saturation over FiO2, which may be better than FiO2 on its own. And then more recently, there's been a lot of work looking at the role of lung ultrasound in diagnosing RDS. And there's also been some work looking at biochemical tests for surfactant presence, or using the ventilator to do tests which can help detect the stiffness of the lung or the lung reactants. So the lung ultrasound of these is probably the best way of moving forward. There's a system now that you can learn for scoring the appearances of lung ultrasound. So you've got 0, 1, 2, 3 with air, evidence of fluid, RDS developing, and then consolidation. And if you apply a systematic approach to doing these scores in different areas of the lung, front and back, you can get a numerical value. And then these numerical values do correlate quite closely with measures of oxygenation, such as the oxygenation index or the arterial to alveolar ratio. And people who have been developing these techniques have done trials to determine if these measurements can predict surfactant need. So this is one such study from Raimondi, published in 2021. 240 babies were followed, of whom 108 had received surfactant. They had their lung ultrasound scores done, and by looking at the lung ultrasound score, they could have predicted which babies were going to need surfactant probably better than they would have predicted using just the FiO2 on its own. And whenever you combined the lung ultrasound scores with another measure of SpO2 over FiO2, you got an even better predictive test. So this is probably the way forward in terms of trying to decide, even before the FiO2 reaches 0.3, whether infants might require surfactant therapy. And then there's the test which has been developed in Scandinavia by Henrik Werner's group, which can measure for the presence of surfactant in gastric aspirate as a simple bedside test. It's been through phase 2 trials and it's currently in phase 3 trials, so it's not quite ready to make a recommendation on it yet, but it'd be interesting if we're able to do a simple test which tells us whether to treat or not rather than waiting. And again, the lung reactants, there's been work from Anna Lapizzari and her group in Milan, which has shown us that for infants that are preterm, by using the forced oscillation technique, you do get a test which can be predictive of subsequent surfactant use. And again, it's not enough data to make a recommendation for doing it yet, but it'll be interesting to see if this is potentially another way forward for deciding when surfactant is needed. So I'm going to move on to talking about how to get surfactant in. So most of the studies that were done in the 1980s and 1990s, surfactant was given to babies who were ventilated through their endotracheal tube. The surfactant was given by bolus and then distributed by ventilation or by bagging it in. And these early studies showed a dramatic improvement in survival with reduction of air leaks, but there was no reduction in BPD. And that might be because more babies were surviving who were at risk of BPD. But there are other ways of getting surfactant in. So in Scandinavia, again, Henrik Werder's group developed the INSURE technique. That's where a baby gets intubated, given surfactant, then immediately extubated back to CPAP. There's been at least 5 clinical trials of INSURE, which have shown us collectively in this Cochrane review that if you use INSURE, you can reduce the need for mechanical ventilation, you reduce the risk of pneumothoraces, and you reduce the risk of chronic oxygen dependency or chronic lung disease. But then now we have this new kid on the block who's come along in the last 10 years, the thin catheter technique, or LISA, less invasive surfactant administration. And there's been lots of studies, as I've shown you already, comparing LISA both with the INSURE technique and with surfactant by endotracheal tube. And this is looking at the outcome of needing intubation. You can see that INSURE, the thin catheter is better than INSURE in terms of reducing the need for mechanical ventilation. And thin catheter surfactant is also better than INSURE at reducing the combined outcome of death or BPD. So nowadays we believe that LISA is better than intubation or INSURE at reducing the need for ventilation and reducing BPD. But there are, again, other ways of getting surfactant in, which have come along in the last few years. And one of these is to give surfactant using a supraglottic airway or laryngeal mask. The first study of this was done by Carrie Roberts in the United States, published 2018. She randomized 100 infants, 28 to 35 weeks gestation, who were more than 1250 grams, who were requiring oxygen of 0.3 to 0.4 on CPAP. And they were randomized to receiving surfactant by laryngeal mask or just continuing CPAP. And the way she did it in her protocol was to give 200 milligrams per kilo and 2 ml aliquots, and then manually ventilate the surfactant in. And after the procedure, the infant was put back on the nasal CPAP. And you can see from the first trial, the average weight of the babies was about 2 kilos with an average gestation of about 32 weeks. And in her trial, she was able to show us that giving the supraglottic airway surfactant significantly reduced the need for intubation and mechanical ventilation, with the greatest effect seen in the least mature infants at higher risk of RDS. And since then, there have been at least 6 trials of surfactant by laryngeal mask, which have been subjected to a systematic review, which is published in the American Journal of Perinatology. And we can say with reasonable confidence that surfactant by LMA will improve oxygenation, and it decreases the need for intubation, it decreases the need for mechanical ventilation. But because the population is more mature and maybe not particularly high risk of BPD, there's been no differences in outcomes like death, BPD, and pneumothoraces. But I think most units with who do NICU are developing protocols now for using laryngeal masks for a certain subgroup of babies who are a little bit bigger to give them their surfactant therapy. There's also been work on surfactant nebulization. About 5 or 6 trials have been done. There was a big effect from the USA trial by Cummings, which seemed to show a reduction in the need for mechanical ventilation, but this was a very poorly designed study with no particular enrollment criteria and no criteria for deciding when to intubate, etc. So the problem is when you do systematic reviews and you put not good data in, you can sometimes get the wrong answer. And having been involved in one of the surfactant nebulization trials, I'm not convinced that it will make a big difference to the population of babies that we are interested in trying to keep off the ventilator. And there's still currently some further studies underway with different types of nebulizer, which hopefully might show an improvement. But at the moment, I don't think we can recommend surfactant by nebulizer. So the current recommendations are that if a baby requires intubation, they should be given surfactant. If they need surfactant, they should be given an animal-derived surfactant where possible. Thin catheter surfactant is the preferred method of surfactant administration, although we can now use laryngeal mask surfactant for more mature infants, more than 1 kilo. If we're using poractant, we should use a bigger dose of 200 per kilo rather than 100 per kilo, because there's a survival difference and also a reduction in the need for retreatment. We should use rescue surfactant early in the course of the disease, and the suggested protocol is to treat worsening babies when the FiO2 exceeds 0.3 on a CPAP pressure of at least 6, or new recommendation if lung ultrasound suggests RDS. And we should give a second and occasionally even a third dose of surfactant if there's ongoing evidence of RDS, such as a persistent high FiO2 requirement and other problems have been excluded. The guideline also touches on recommendations for things like non-invasive support, mechanical ventilation, etc. I haven't time to go through everything today, except to say that at present it seems that NIPPV is coming to the fore as a good method of respiratory support for babies, both when they come off mechanical ventilation as the primary mode of support in terms of reducing the need for reintubation, and even giving NIPPV as a primary mode of support. And there's been some evidence to show that there's less BPD when compared to CPAP. And there's evidence that there's also less nasal injury if you're using high flow compared to CPAP. So at present, NIPPV is becoming more popular. And there are obviously different strategies for mechanical ventilation, which all need to be considered. And just to summarize, I think we should be trying to aim towards developing protocols where we're using lung protective strategies like volume targeting ventilation or high frequency oscillation ventilation, because these do significantly reduce the risk of oxygen dependency at 36 weeks. And there's also in the guidelines a mention of strategies for minimizing ventilation, such as caffeine, permissive hypercarbia, using postnatal steroids, etc. And of these, I think caffeine is the most important. The largest body of evidence for caffeine still comes from the CAP trial, which is now 18 years old. So in this study, more than 2,000 babies less than 1250 grams were randomized to caffeine or placebo. And the babies who got caffeine were extubated a week earlier, came off CPAP a week earlier, came off oxygen a week earlier, and had significantly less BPD and less use of steroids for BPD. And when they were followed up at 2 years, 5 years, 11 years, they actually had an improved neurodevelopmental outcome, probably on the basis of reduced BPD rather than a direct effect of the drug on the brain. So we should have protocols for starting caffeine early to try and minimize the use of mechanical ventilation. So thank you very much for your attention, and hopefully I'll be able to join you on the day to answer any questions that you might have. All the best. Bye-bye.